Thank you to the conference organisers for the invitation to talk to you about the clinical management of COVID-19, focusing upon the experience from Australia. My name is Professor Greg Fox and I'm a respiratory physician practicing at Royal Prince Alfred Hospital in Sydney, Australia. And I'm pleased to share with you today some of our experiences in managing COVID-19, both from the perspective of the community as well as from healthcare facilities. I'll be sharing with you some of the strategies that we've used to treat patients, talk about the public health response, and also some clinical algorithms that we use in our hospital, including both pharmacological and non-pharmacological treatments. And I'll conclude with a case to go and illustrate some of the challenges that we face. The COVID-19 pandemic in Australia has had a profound effect on many aspects of the healthcare system. As you can see here, these data from the Australian federal government show that during the early and mid parts of 2020, there were substantial outbreaks in Australia's largest cities, which were rapidly contained as a result of stringent lockdowns and social distancing measures. For most of the subsequent 8 or 9 months, there was almost no community transmission. But with the arrival of the Delta variant in mid-2021, there was a rapid rise in case numbers, predominantly in Australia's two largest cities, Sydney and Melbourne. And fortunately, as a result of increased rates of vaccination and a result of public health measures, the numbers of cases in this latest outbreak have now begun to decrease, and there's been much lower rates of mortality as the vaccine rate has increased. We can see in Australia that although predominantly younger people have been affected by COVID-19, that the mortality has been primarily concentrated in people who are over the age of 60. And this mirrors the experience in many other countries in the world. Australia's experience is that the spread of COVID-19 has been very heterogeneous. So in the largest, most populous states, Victoria and New South Wales, there have been large case numbers. And in other states where there's been very little spread, there's been almost no community transmission. And so as I record this at the start of November 2021, some states have been able to eliminate COVID-19. However, as borders open and as vaccination rates have increased, all of these states are going to eventually face the challenge of managing COVID-19. So first of all, I'd like to talk about what has changed in the management of COVID-19 since the start of the pandemic. You may recall going back to the start of 2020 that the world encountered a new virus for which there were no known treatments. And since that time, there's been a staggering amount of research that's been conducted, and therefore we have a much better evidence-based practice now around how to treat COVID-19 than we did 18 months ago. Secondly, in many countries in the world, vaccination rates have been very high. And this is particularly the case in Australia. In New South Wales, my state, first dose rates are now approximately 94%, which means that there's a very different epidemiology of COVID-19 compared to what there was in the previous outbreaks. Thirdly, as a result of a scale up of resources, shortages of personal protective equipment are much less common now. And also we have much faster methods for detecting the presence of the SARS-CoV-2 virus. And so in our hospital system, we use a combination of Liat, GeneXpert, and Panther tests, depending upon the urgency of the decision to test. And in fact, we have now instituted frequent screening healthcare workers who are in regular contact with patients who have COVID-19. But really the biggest change in 2021 has been the arrival of the Delta variant, which completely changed our understanding of how to manage patients because of the increased infectiousness in the healthcare setting, and also because of the greater case numbers that resulted from more community transmission. So in the local health district in Sydney, where I work, we could break the management of COVID-19 down into two parts. We could talk about management in the community and management in the healthcare setting. Now, because there's a large number of patients who developed COVID-19 who are minimally symptomatic, who don't have very severe disease, we've really tried to keep these people out of hospital and away from transmitting to other people. And so as a result, the vast majority of patients who develop COVID-19 are managed in their homes. They'll be supported by remote monitoring from hospitals. And if they become unwell, then they would be assessed in the emergency department. And the reason that we've taken that approach is to minimize crowding in hospitals and also to minimize the unnecessary transmission of the virus for people who may otherwise have minimal symptoms. And it's also important to recognize that hospitalization can be a deterrent for people coming forward for testing for COVID-19. Now, in our local health district, we've had an innovative community-based program called RPA Virtual. RPA Virtual is a virtual hospital which manages patients using tablet computers and remote oxygen saturation monitors. And so for patients who are at high risk, they'll have a nurse deliver them an oxygen sats monitor at home, and that will be reported at least 3 times a day back to the hospital with 24-hour nursing and medical service, as well as additional supports for people with psychological concerns. Now, this model of care has seen treatment of thousands of patients in our community and has resulted in a substantial reduction in the burden to hospitals. And there are variants of this which have been implemented in other parts of Sydney and other parts of Australia. One of the key to managing COVID-19 in the community is effective communication to patients. And so as a result, every patient who has a diagnosis of COVID-19 receives a detailed letter which tells them about the disease, that tells them about what to do if they become unwell, including phone numbers to call. And so this really helps to reassure people that enables them to stay at home. In addition, we give people practical tips about how they can be assessing their own needs. And if they have difficulty getting food or being able to do daily activities, they can call a hotline to get advice from the RPA Virtual staff. And if people are feeling unwell, then they call an ambulance and get taken to hospital. Now, the community setting has treated most patients, but for patients who become more unwell, then they need to be treated in a tertiary healthcare facility. And so I'm going to talk to you now about some of the approaches that we've taken in Sydney Local Health District to managing the complex changes with COVID-19. The first point to make is that the response to COVID-19 has been a coordinated and multidisciplinary approach. It's really brought together all of the different parts of the hospital, including the hospital executive, the different departments involved in caring, including the emergency department, intensive care, respiratory medicine, infectious disease, and infection control, and brought in other doctors from other departments. The core management decisions have been made at a daily operational meeting where patients who are being considered for discharge are discussed by a multidisciplinary group. And this is through the daily multidisciplinary team meeting. There have been detailed processes and policies have developed. Wards have been repurposed, including engineering changes to improve airflow. And there's been capital works to go and create negative pressure rooms. There's also been technology updates to allow for data to be recorded to the electronic medical record, and staff have been redeployed. There's been education for staff across the health system, including in supply of oxygen and other more advanced life support techniques. And there's been a new language or lexicon that have been developed so that people can understand how to manage patients in different parts of the hospital. In addition, there's been a coordinated response to critical events such that there are fixed processes if a patient requires assessment for more intensive treatment. And outside of the core medical support services, we've also been working very closely with other medical specialties, with radiology, and also with the public health service for people once they're discharged from hospital. And so you can see here that there's really an entire hospital response to COVID-19. And we've also had to include some of the non-clinical roles as well in this. such as security for patients who may be agitated or where there are behavioural disturbances. And we've also been working with the maternity and obstetrics service to go and provide safe care for women. So this is a hospital which is a general hospital that has both adult as well as paediatric medicine. This is an image of one of the COVID wards at RPA Hospital in Sydney. And you can see here some features of the re-engineering. So there are negative pressure rooms which have been set up. There's purpose-built facilities for disposing of personal protective equipment for donning and doffing, and staff are trained in how to go and do this and are observed when they're donning and doffing their personal protective equipment to minimise transmission. You can also see here a display with patient details. And typically during a daily ward round, the doctors would walk around with a telephone and call and speak to the patients through the glass rather than having to directly have contact and therefore risk nosocomial infection. This is a figure just to show the way that the hospital has been reorganised. So the hospital has a number of red wards, which are wards where there are patients with known COVID. There are pathway wards or orange wards, which have people who have possible COVID, such as people who have been exposed to patients or people in the community with COVID, but who do not yet have a positive test. And then there are green wards where people have been cleared of having COVID. And we really have separated different parts of the hospital in order to ensure that, that we minimise hospital transmission and minimise the risk to staff. And of course, all staff have been vaccinated as soon as that became available. In addition, we developed specific guidance around how to deal with different acute situations. So if patients became unwell from the point of view of their breathing, then basic life support guidance was given, particularly to go and avoid people performing procedures that may risk transmission to the person who's attending the patient. We also have procedures around behavioural disturbances, both for confused patients and also for patients that may be unwilling to stay in isolation under the public health order. And that's to protect both staff and other members of the public. So the coordination of the hospital approach has been through regular Zoom meetings, through the use of online sharing of resources such as guidelines, through support for junior staff by education and online videos, as well as widespread diagnostic testing, including routine testing for staff every 3 days who are on a COVID ward, and in the period after they're discharged, that they leave the COVID ward, as well as infection control practices and guidelines. I'm now going to speak a little bit about the specific clinical management approaches to COVID-19 that we've been adopting. One of the most important parts of treatment is oxygen therapy. And it's important to make a decision about who should receive oxygen and to look at the trajectory of the patients to make sure that people who are becoming hypoxemic despite oxygen are flagged for more intensive assessment. And so as you can see here, there's a range of different oxygen treatment options, beginning with just low flow nasal cannulate oxygen, stepping up to high flow nasal prong oxygen, which can be delivered through specifically designed devices that deliver high flows of oxygen and also positive expiratory pressure, CPAP, or continuous positive airway pressure for patients who may be becoming more unwell, and also the use of conscious proning, as I'll discuss in a minute. And in particular, in relation to conscious proning, there is now good evidence from an open label meta trial to show that the use of awake prone positioning compared to standard of care reduced intubation by about 25% and reduced mortality by about 13%. So simply positioning the patients can have a significant impact. And finally, we have a respiratory support service, which provides assistance for people, particularly for nurses who may not be familiar with delivery of these oxygen therapies. Coming back to the point about proning. So this is a technique which has no cost associated with it and that can potentially save lives. So by positioning patients lying prone or face down while they're awake. This can help to improve the expansion of their lung units and ventilation perfusion matching. So in patients who are hypoxemic, this is preferred. And you can see here some guidelines for conscious self-proning. So this is particularly for patients who require supplemental oxygen and who are not responding to the initial treatment. You need to communicate with the patient and ensure that they can cooperate, because some patients may not be able to do this, and then rotate into a prone position and then ensure that they can adjust their position independently. It's important to be sure that there are no contraindications, such as airway patency issues, respiratory distress, including a rapid respiratory rate or accessory muscle use or a high carbon dioxide. The need for, another contraindication is the need for escalation to intubation, agitation, hemodynamic instability, spinal or thoracic injuries, as well as neurological issues, morbid obesity, and pregnancy in the second or third trimester, or concerned around pressure areas. So once these have been excluded, self-proning is a very simple technique which can make a difference. This figure here just shows one of our algorithms for the use of oxygen and for stepping people up to high levels of oxygen. So in our practice, patients who are on 6 litres by Hudson mask and have hypoxemia of less than 92% are considered for high flow nasal prong oxygen, or CPAP. And it's of course important to ensure that these resources are used appropriately so that oxygen is not wasted, because it's a precious resource. So we need to make sure that patients are in fact receiving an appropriate amount of oxygen supply. The settings that we use in CPAP are 10 centimetres of water as an initial setting for people who are requiring a higher flow of oxygen, and it can deliver up to a 60% FiO2 on the wards under our conditions. And then there are criteria for escalating to intensive care review if the hypoxemia becomes worse despite this treatment. And palliative care is also an important part of treatment. At the point that the patients are admitted to hospital or to the ward, a decision needs to be made around the threshold of care, which is acceptable. And so if a limit of care is put in place, for example, ward-based care, this needs to be documented to ensure that patients don't receive futile treatment, which may cause them discomfort. And that's particularly for patients who may have more severe comorbidities or have poor prognostic features, which means that they're unlikely to be able to leave the intensive care unit if they were to be intubated. Now, I'm going to talk briefly about COVID-19 therapeutics. This has been reviewed extensively, and I'd encourage people to look at the Australian government website for a very helpful summary of the evidence around these treatments. Basically, they can be grouped into prevention, treatment of COVID-19, and then additional therapies for complications. So for prevention, sotrovimab can be used, although this is not usually available by the time a person comes to hospital. Treatment options, including dexamethasone, remdesivir, tocilizumab, and baricitinib, all of which are used in our hospital, and then sometimes antibiotics. As I'll explain, there's a very limited role for antibiotics just for those who develop complications later in disease. Now, the phases of COVID-19 begin with a rapid viral response, and then the host inflammatory response increases. And so the therapies are designed in order to go and try and mirror that those stages. So antibody therapies such as sotrovimab can be given early in disease as a way of trying to go and reduce the number of the viral replications in the patient. Antivirals can be used during this phase, such as remdesivir, although the evidence for that is fairly limited. And then immunomodulatory therapy to reduce this host inflammatory response phase, which causes much of the damage and the morbidity associated with COVID-19, and dexamethasone being the one which is cheap and very effective. Now, the evidence for dexamethasone comes from a number of studies, particularly the recovery trial. And this trial showed a reduction in mortality in patients requiring respiratory support there was no clear benefit of dexamethasone in patients not requiring supplemental oxygen. And so for that reason, in our hospital, we reserve dexamethasone 6 milligrams daily for patients who have an oxygen requirement. That is, that they are hypoxemic on room air and require oxygen. It's therefore recommended for inpatients requiring supplemental oxygen and not given to outpatients. Of course, there are side effects relating to steroid use, including high sugars and sometimes neuropsychiatric effects. Sotrovimab that I've mentioned can be given if it's less than 5 days since symptom onset, and if a patient is not fully vaccinated and has at least one of these comorbidities. Now, these patients are a fairly small proportion of the total number of patients who develop COVID-19, but this drug may have benefit. And we particularly focus on people such as those with chronic kidney disease or severe COPD who we think are going to do poorly. Baricitinib is a JAK kinase inhibitor, which is commonly given for patients who are hospitalized with COVID-19 and who have more severe disease. And usually we look for evidence of inflammation when deciding to give this, particularly radiologically, and also based on inflammatory markers such as C-reactive protein being elevated. This evidence is based upon an international RCT, which found a significant reduction in mortality with a hazard ratio of 0.57 at 28 days. But there was no significant difference in serious adverse events, including infection, which is reassuring. So this treatment has become a standard part of our treatment for inpatients, in particular those who require oxygen and have evidence of inflammation, as I've mentioned. So we would not give these to patients who have early and very mild disease. We typically give this as 4 milligram tablets for 14 days, and the dose can be adjusted for renal impairment. You can see the adverse events listed there. I want to make a brief comment about antibiotics in COVID-19. Antibiotics are not appropriate as a first-line therapy for COVID-19, and in fact can cause complications for patients. Unfortunately, it's difficult because many of the symptoms and signs and radiological criteria of COVID-19 overlap with bacterial infections. And we know that bacterial infections can complicate COVID-19 later in the course. And it's been shown that, in fact, antibiotic prescribing was very common amongst this large meta-analysis. But that bacterial co-infection was actually very uncommon, and mostly it occurred more than 48 hours after admission. And antibiotic prescribing in this meta-analysis was associated with increasing patient age and COVID-19 severity. Antibiotics cause complications, including Clostridium difficile infection, antimicrobial resistance, and also liver and kidney injury. And so therefore, this is the approach which I would recommend, that antibiotics are rarely required on initial presentation with COVID-19, and so therefore they shouldn't be the first treatment given. A minority of patients will develop a bacterial co-infection, and atypical pneumonia treatment is not required, and not all bacteria isolated from the respiratory tract specimens require treatment. And also, we should be evaluating for secondary bacterial infection and considering antibiotics in patients who become febrile after being afebrile or having a persistent prolonged fever, people who have new respiratory symptoms such as purulent sputum, where they didn't at the start, or people who have new pulmonary consolidation on imaging, although of course COVID-19 pneumonitis can cause this as well. I'm just going to conclude with a brief case study to illustrate some of these issues. So this is a 62-year-old male who had COVID-19. He was a non-smoker, unvaccinated, and he was obese with a body mass index of 30. He presented to hospital on day 7 after symptom onset and day 5 after swab positivity with hypoxemia at home. He looked well and had an oxygen requirement and a normal cardiorespiratory examination. The chest X-ray showed some mild interstitial changes, and his lymphocytes were 0.5. He had a D-dimer which is mildly elevated and a significantly elevated C-reactive protein and no troponin abnormality. So at this stage, the questions to consider were, how stable was he? So to begin with, the basic airway, breathing, and circulation, ABC, to make sure that he was stable. Secondly, to consider supplemental oxygen and what other respiratory support was required. Thirdly, at the point of admission, to consider the ceiling of care. Was this patient suitable for more aggressive therapy, or should a palliative approach be taken if he became unwell? And in this case, because he was a young, relatively healthy male, the decision was made to proceed with all active measures. The question after that was the location of care. Should he be managed in a ward or an intensive care unit? And in this case, the ward was appropriate because of the low level of oxygen. What COVID-specific therapies should be given? So what drugs that I mentioned before, and what are the prognostic factors to guide decision-making about his ceiling of care, and what is likely to happen based upon his comorbidities. So in his case, he was admitted, he had some poor prognostic markers, such as his smoking history and his slightly older age of 62. He was admitted to a COVID-specific or red ward, and he was continued on nasal prong oxygen. He was given dexamethasone and a proton pump inhibitor to reduce the complication of gastroesophageal reflux and gastritis. And he was given enoxaparin, which is to prevent blood clots, which is a standard dose that we give to patients who are inpatients with COVID-19, and used for full active measures. This is an image which shows the electronic medical record, and you can see here the oxygen saturations going from right to left as time passes. And you can see here that at about 4:45 p.m. on this date, the patient became hypoxemic, and so therefore was needed to be increased his oxygen flow to 6 litres per minute by Hudson mask. He managed to remain stable over this time, but had an intensive care review. And you can see that some of the interstitial changes are now increasing, particularly on the right here on this chest X-ray. So the question is, what else can be done? And as I've described before, in addition to the tablet therapy, so baricitinib, which is appropriate in this patient given he's hypoxemic and he's got high inflammatory markers, proning was also an intervention which we could do, which in English we call tummy time. And so this therapy was initiated, and it managed to keep him relatively stable overnight. However, the next morning, he became more hypoxemic and had a higher oxygen requirement with an FiO2 of 66%. And so therefore, he needed to be sent to the intensive care unit and progressed to intermittent mechanical ventilation. So this is an example of a typical patient who gets worse. Of course, as would be the case in any country in the world, most patients who develop hypoxemia do not require intubation. And so if he had continued to be stable, then he would have, once his oxygen requirement decreased, be transferred back to the community. So this is an example of typical management of a patient who has progressive COVID-19. And as with many of our patients, this patient had a prolonged ICU admission and a difficult post-intubation course. Which just leads me to the final point today, which is around post-COVID care. So we've been beginning to recognize the significant complications of COVID-19 for a minority of patients. Some patients have great difficulty even being discharged from the hospital because of an ongoing oxygen requirement. And some patients have ongoing respiratory needs, such as tracheostomies or the need for chest drains due to pneumothoraces. And so these patients are very difficult to manage and very difficult to discharge. There's also complications of intensive care and of prolonged therapy, including gastrointestinal bleeding, stroke, and secondary infections as well, and other respiratory complications. Neuromuscular deficits are common in patients who've had prolonged intubation, and particularly for patients who've been on ECMO, there can be difficulties, and mental health issues, including memory loss and ongoing anxiety and depression are also commonly seen in patients who've had prolonged hospitalizations. And of course, isolation from families during this period is difficult. Now, in our hospital, we've begun planning for a post-COVID respiratory clinic to manage patients who have long-term disability associated with their lung disease. And in fact, it really requires a multidisciplinary approach, because the long-term complications of COVID-19 are not just respiratory, but they're also often cardiac, neurological, psychiatric, and also musculoskeletal. So it's very important to have a multidisciplinary approach to patients. And so we're following up our patients in an outpatient setting and planning to provide intensive physiotherapy, particularly for those who have difficulty with adjusting to returning home. So I'll conclude there and just make a few concluding remarks. First of all, that the COVID-19 pandemic has had an immense effect on the rest of the hospital system as well. And so it's been a great challenge for clinicians to be able to continue managing the non-COVID patients as well as those who have developed COVID. Secondly, the use of vaccines has seen a dramatic decline in COVID numbers and COVID hospitalizations. And so I think that's going to be an essential part of the ongoing management of COVID-19 going forward, to try and prevent people from coming to hospital in the first place. And finally, to say that I think we need to continue to do research to look at evidence-based approaches to treating patients with COVID-19. One of the things that has characterized the pandemic has been the use of many non-evidence-based therapies, which can often cause more harm than good. And so I'd really encourage people to look at the evidence-based treatments that I've mentioned, and to particularly avoid unnecessary use of antibiotics and other therapies which may complicate patients' course. So I'd like to thank Dr. Lauren Troy, Dr. Tina Marinelli, and Dr. Simone Visser for slides that they contributed to today's presentation. And again, I'd like to thank the organisers of the conference and wish Vietnam all the best as it meets the challenge of COVID-19. And we are very much thinking about you in Australia, and I think we share many of the same challenges. Thank you very much.